welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our first presenter today is Katie Thompson, a PGY2 EM resident at NewYork-Presbyterian, who will be presenting on Zalunfiban at first medical contact for ST elevation myocardial infarction, the CELEBRATE trial.
So getting into an overview of the trial, the objective was to determine if the use of Zalunfiban at first medical contact in patients that were suspected to have a STEMI and were undergoing a primary PCI improves their initial infarct artery patency and their clinical outcomes. It was a phase 3 multi-center randomized double-blind placebo-controlled trial that was conducted across several countries and funded by Cellacor Therapeutics. Before we get into more details about the trial, I'm going to go over just some high-level background information. So ST segment elevation myocardial infarction, or STEMIs, typically result from atherosclerotic coronary plaque rupture, and this will lead to platelet aggregation and complete coronary vessel occlusions. So early reperfusion strategies, including our classic medications to prevent further complications from the plaque rupture, are associated with improved outcomes. The guidelines recommend aspirin and P2Y12 inhibitors as our first line for patients presenting with STEMI. For aspirin, it is generally recommended to be administered as soon as possible to reduce vascular death and associated MACE. For P2Y12 inhibitors, they're also recommended to be given in combination with aspirin to reduce MACE complications. For intravenous glycoprotein 2B3A inhibitors, there's a recommendation that they can be used for patients undergoing PCI that either have a large thrombus burden, no reflow, or slow flow as an adjunctive agent, so as more of like a rescue or bailout agent, but they're not routinely recommended for the use of ACS because of harm. And just getting into some previous trials that were conducted with glycoprotein 2B3A inhibitors, there was an Admiral trial that was conducted in 2001, and the investigators of that trial were looking at abciximab for acute MI in conjunction with primary coronary stenting. They found that the use of abciximab compared to placebo had better clinical outcomes at 30 days and 6 months. And the clinical outcomes they were looking at included a composite of death, reinfarction, and then urgent revascularization of the target vessel. They also found that patients treated with abciximab had greater frequency of grade 3 kidney flow after revascularization and at 6 months. They also found there was no significant difference between major bleeding, only in minor bleeding. The second trial is on-time 2 trial that was done in 2008 that investigated tirofiban for pre-hospital administration in patients with STEMI. They had a primary endpoint of residual ST segment deviation 1 hour after PCI, which was significantly lower in the tirofiban treated group. They also had significantly less rates of a combined clinical outcome composite that included death, recurrent MI, and then urgent target vessel revascularization, and again, no difference in major bleeding. However, there was another trial done, the early ACS trial, which looked at eptifibatide for upstream administration in patients with non-ST segment elevation ACS within 8 hours of presentation, and they failed to demonstrate an improved benefit for ischemic outcomes. They also noted that there were significantly more bleeding complications with eptifibatide group. There was also another meta-analysis done that includes 16 randomized control trials and over 10,000 patients undergoing primary PCI that received these glycoprotein 2B3A inhibitors that did not find a 30-day reduction in mortality or reinfarction, but significant increase in major bleeding. So getting into the drug of interest, Zalunfiban, this is a novel investigational glycoprotein 2B3A inhibitor. It's going to inhibit fibrinogen binding, platelet aggregation, and platelet thrombus formation by locking the receptor in its inactive state, which is a little bit different than previous generations of glycoprotein inhibitors that can cause conformational changes and lead to side effects like thrombocytopenia. The onset of action is relatively quick, within 15 minutes, and it also has a relatively quick offset, about 2 hours, with a complete platelet restoration at 4 hours. I have a little chart here on the right hand of the screen that just shows the different antiplatelet agents that we use and where they interact on the receptors on the platelet. So Zalunfiban, like others in its class, are going to act on the glycoprotein receptor and inhibit that conformational change and the platelet aggregation. What's novel about this drug is that it is administered subcutaneously when we compare it to our previous generations, which are intravenous administrations followed by continuous infusions. So getting into the trial, patients were included if they were males 18 years or older, postmenopausal or surgically sterile females aged 50 years or 55 years or older for certain sites, weighing between 52 to 130 kilos, and presenting with a STEMI that was defined as persistent chest pain for more than 10 minutes and new ST segment elevation of greater than 2. They also had to present within 4 hours of their symptoms and had planned to be transported to a participating site. Patients were excluded if they were receiving CPR for an out-of-hospital cardiac arrest, if they were in cardiogenic shock, which the trial investigators defined as systolic blood pressure less than 90, confirmed on multiple readings, and a heart rate of greater than 100 beats per minute. Patients were also excluded if they had active COVID-19, on dialysis, active anticoagulation treatment, major surgery, trauma, or bleeding that required hospitalization within the last 30 days, a known history of stroke, regardless if it was ischemic or hemorrhagic, and then if they were anemic requiring regular transfusions. Participants were randomized in a 1:1:1 ratio to receive a single subcutaneous dose of Zalunfiban at 2 different doses, 0.11 mg per kg sub-Q or 0.13 mg per kg, or to a matching placebo group. And it's of note to mention that patients were allowed to receive standard of care as well, which included aspirin, P2Y12 inhibitors, and also heparin. The primary efficacy outcome was a composite of a ranked 7-point scale, and that include all-cause mortality, stroke, recurrent MI, acute stent thrombosis within 24 hours, new onset heart failure, a larger MI within 24 hours after randomization, which they defined as a high sensitivity troponin 30 times more than the upper limit of normal, or none of the above. For safety outcomes, the primary safety outcome was Gusto-defined severe or life-threatening bleeding at 30 days, which is defined as intracerebral hemorrhage or bleeding resulting in hemodynamic compromise that requires intervention. Secondary efficacy outcomes included a corrected TIMI frame count at the index angiography, ST segment deviation 1 hour after the PCI, and then blinded bailout use of additional antiplatelet agents. Secondary safety outcomes included Gusto-defined minor to moderate bleeding at 30 days. Moderate bleeding is defined as bleeding requiring transfusion but not resulting in hemodynamic compromise, and then minor bleeding not meeting the moderate or severe criteria. Additionally, thrombocytopenia and injection site reactions were also observed. The investigators estimated that about 2,300 patients would provide 90% power, and they accounted for a 6.6% attrition rate, with the final target enrollment being about 2,500 patients and about 830 per group. Of note, the analysis for the 2 different Zalunfiban groups were pooled for comparison to placebo. The primary efficacy endpoint was a hierarchical proportional odds model. The primary safety endpoint was analyzed compared between groups using a Fisher's exact test, and then secondary endpoints were analyzed using Fisher's exact test for categorical data, ANOVA for continuous data, Kaplan-Meier estimates for time to event data, and then survival distributions and long-read tests for treatment differences. For the results, about 2,500 patients were randomly assigned and about 800 patients per group. They did not report on the number of patients screened or reasons for exclusion. The average patient was a white male, aged 62 years, with a BMI of 27.4 and enrolled in the enrollment site of an ambulance. Of note, over 72% of the patients that were enrolled were in the Netherlands. Additionally, some important demographics and baseline characteristics I wanted to point out include the time intervals. So from symptom onset to diagnostic ECG, it was about an hour for both groups. And then from symptom onset to trial drug, it was about 90 minutes. From symptom onset to angiography, it was about 127 minutes. And then from study drug to angiography, it was about 30 minutes, so relatively quickly. From trial drug to actual PCI, it was about a little less than an hour. The majority of the patients had an interior MI and were treated with both heparin and a P2Y12. The exact number of which P2Y12 inhibitors were used were not listed. However, it was mentioned in the study that ticagrelor was the most common agent. Getting into the results. So here are the hierarchical proportional odds model for the primary endpoints, and they reported an overall odds ratio for these outcomes. So treatment with Zalunfiban reduced the risk of overall events by 21% when compared to placebo. And they also provided a table that breaks down the different components individually. So when they were analyzed in this way, the benefit was driven by a reduction in the risk of acute stent thrombosis within 24 hours and a larger MI. They also looked at subgroup analyses. Of note, this data was not adjusted for multiplicity, so you can't draw conclusions from it. However, it is interesting to note that patients who did not receive P2Y12 inhibitors as pre-treatment had a stronger correlation that favors Zalunfiban, and also patients that received the study drug in the pre-hospital setting versus in the hospital setting also have favored Zalunfiban. For key secondary outcomes, so the patency of the infarct-related artery prior to angiography was significantly better among the Zalunfiban-treated patients compared to placebo. And then in total, about 52% of patients in the treatment arm had a TIMI grade 2 or 3 flow in the infarct-related artery compared to 45% with the placebo group. However, these are exploratory secondary outcomes for the TIMI grade 2 or 3 flow. So again, no conclusions could be drawn from that. For safety outcomes, for severe life-threatening bleeding, the rates were not significant between the Zalunfiban and placebo arms, but there was an increase in mild to moderate bleeding with 6.4% in the Zalunfiban group and 2.5% in the placebo group. There were no differences in the risk of intracranial hemorrhage or gastrointestinal bleeding in the treatment arms. And there were no significant differences in thrombocytopenia, but there were more injection site reactions with the Zalunfiban group. Getting into the strengths of the trial, so overall it is a well-designed trial. It was large, placebo-controlled, and it spanned across several countries. And it did include patients that were receiving standard of care, which I feel like increases the generalizability to patients. And then for limitations, we were missing data for the total number of patients screened and excluded. There are some logistical concerns for pre-hospital administration. I looked up some statistics for the Netherlands, and what I found was EMS personnel in the Netherlands have a licensed critical care nurse on their ambulances. And they also have a mandate where you have to respond within 15 minutes to medical emergencies with over a 95% compliance rate with that, which differs from some of the practices here over in the US, especially in New York. And then there was no superior benefit of administration, whether it was in the patient's home or ambulance versus in the emergency department. There were no conclusive data to explain where the benefit was with the administration of Zalunfiban. Additionally, the pooled Zalunfiban analysis of both the doses limits if there are dose-specific benefits. Additionally, the majority of the patients were Caucasian males, which limits generalizability to other demographics. And I would have liked to seen an incidence of what specific P2Y12 inhibitor was administered, but that was not reported. It was just mentioned that ticagrelor was the most common. So to wrap up the trial, Zalunfiban administered at first medical contact for patients with STEMI did improve initial vessel patency and reduce adverse clinical outcomes at 30 days. Zalunfiban didn't increase the risk of major bleeding compared to placebo, but it did increase the risk of mild to moderate bleeding. And then I think additional studies are needed and more real-world data to determine if this is worth implementing in standard of care for STEMI, especially considering the differences in pre-hospital care. The majority of these patients were treated compared to where we are, at least in New York, where I practice. And with that being said, I will open up the floor to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.